Hello everyone, welcome to Neurological Concepts Made Easy. In this video, we are going to discuss about reflexes, and here in this video, we are going to discuss about the abnormalities in a deep tendon reflex. So it is a part 2 video, a continuation of the previous video. So what are all the factors which we should assess while eliciting a reflex? We should look for the latency for the response to happen, the speed of response, the range of movement, then the threshold for response, and the duration of muscle contraction. So let me explain this. So when you do a knee jerk, when you are tapping over the just below the patella or the just above the tibial tuberosity, so what happens is the knee extension, right? When you are doing a knee jerk, there is going to be a knee extension. So the latency is nothing but the time difference between you tapping the tendon and the knee extension. So that will be the latency. The speed of response is again a very similar thing, where the velocity of movement will be taken into account. And the range of movement is nothing but how much does the knee extension go. Then the threshold for response is nothing but either is it a gentle tap or even a touch. Sometimes when reflex is very high, when due to some human pathology, when the reflexes are hyperreflexic, you can even elicit the reflex with a finger tap. You don't need to use a knee hammer to do that. So that is where the threshold for the response is happening. A threshold, a very minimal threshold means the very minimal threshold is needed to elicit a response means then it is going to be hyperreflexic. Okay. And then the duration of muscle contraction. So for how long that muscle contraction is happening. As in the case of clonus, when you can see, not essentially we are discussing clonus and reflex, something like that. The duration for which the muscle contraction is actually happening. So all these you assess in a normal reflex. So basically you look for the latency for the response to happen, the speed of the response, the range of movement. For example, when you do a knee jerk in a hyperreflexic patient, so let's say a cervical compressive myelopathy, so what happens is when you do that knee jerk, if you stand in front of the patient and the knee jerk is going to be something like a 3 plus or a 4 plus, there's a chance that the knee extension may come so much that he can hit you. So that is how the range of movement can be. It can be very wide. And then the threshold for response and duration of muscle contraction. So all these you have to assess while eliciting a normal reflex. So what are all the abnormalities that can happen in a DTR? So normal DTR, it is 2. Grading is 2. So anything that is 0 or 1 will be hypoactive. So hypoactive as in it can be diminished or sluggish. That is grade 1, or it can be completely absent. So that is grade 0. Then it is hyperactive. Hyperactive is grade 3 and grade 4. Grade 3 is not pathological, but grade 4 is certainly pathological. So if it is going to be hyperactive, then you can see the latency will be reduced. So the time duration for which the tapping the tendon and eliciting the response will be reduced. The speed will be increased and the vigor of response will also be increased. The range of movement, like I told you, it will be very much. A threshold to elicit it, even you can elicit it with a finger tap. And the extension of reflexogenic zone. This you can very well see. Usually where do you tap it to elicit a response in the case of a knee jerk? Just below the patella, that is in the region of the tibial, just above the tibial tuberosity you tap. But even above the patella, suprapatellar, you can tap it and you can elicit a knee jerk in a patient with hyperreflex, a grade 3 or a grade 4 reflex. So that is what is called as the extension of the reflexogenic zone and a prolonged muscle contraction. So all these are features of hyperactive reflex. So now let's go one by one. Hypoactive reflex, it is going to be a sluggish response. The range of movement will be diminished. And before you tell a deep tendon reflex to be absent, you have to make sure that even with applying a reinforcement maneuver like a Gendrasic maneuver or gritting the teeth or whatever, even after applying that, you are not able to elicit the reflex. That is what is called as absent DTR. So what are the causes for this hypoactive reflex? It happens due to a lower motor neuron pathology, full stop. It happens due to a lower motor neuron pathology. So it is due to a dysfunction of some component of the reflex arc. As you know, the reflex arc has an afferent and then efferent or even the spinal cord, which is the center. So any problem there is going to be responsible for a hypoactive reflex. So if the pathology were to involve the afferent limb, as in a lesion of the sensory nerve or in the posterior root ganglion or intramedullary pathways, as in the case of syringomyelia, all these are involved the afferent limb. So if it were to be the efferent limb, it could be the motor unit, as in a radiculopathy or peripheral nerve lesion. So all these are the inferences for a hypoactive reflex. That is a grade 0 or a grade 1. And what happens to reflex in spinal shock? This is very important. Examiners are very fond of this. So in spinal shock, the reflex is absent due to sudden transverse lesion of the spinal cord. But after a period of 3 to 4 weeks, it will reappear and then it becomes hyperactive because spasticity will eventually set in and the reflexes become a hyperactive kind of thing. So initially there will be absent reflex, but as time progresses, it will be a hyperactive reflex. So are there any other conditions where the deep tendon reflexes may be reduced or absent? In deep coma, narcotic ingestion, heavy sedation, a deep sleep, following nerve block or spinal anesthesia. So all these are conditions where the deep tendon reflexes can be reduced or absent. These need not be essentially pathological involving the element region, but a diffuse thing. Okay, so you have to keep all this in mind. So what is this term called as hung up reflex? So this hung up reflex means, as you know, every reflex has 3 stages. One is this lengthening, that is when you tap the tendon, you are lengthening the tendon. And then there is a contraction phase and then there is a relaxation phase. When the relaxation phase is prolonged, this is what is called as hung up reflex. This is seen especially in ankle jerk, a classical finding in hypothyroidism, and this is called as Voltman's sign. So this is very important for you to remember. So now coming to hyperactive reflexes. So what is this hyperactive reflex? So all the components which I already told you, the decrease in reflex threshold, the latency will be reduced, the power and range of movement will be exaggerated, the prolongation of reflex contraction and the extension of reflexogenic zone, all this will happen. And of course there will be a spread of reflex response. By the term spread of reflex response, we mean multiple groups of muscles can be involved. For a single, when you are trying to test one muscle, other antagonists or nearby muscles, they can get involved. So this is what is called as spread of the reflex response. So what does the hyperactive reflex suggest? It suggests a lesion involving the corticospinal system. That is nothing but a UMN lesion. So lowering the reflex threshold due to increased excitability of the lower motor neuron. So this is what is happening. So the reflex threshold is lowered due to increased excitability of the lower motor neuron. So what are the other causes of hyperactive agitation? Normal individuals, especially in younger women. So now how to physiologically distinguish a brisk reflex from a pathological reflex, that is a grade 3 from a grade 4. So these are the things you have to carefully note. One is the lower extremity tone. So if it is going to be hypertonic, it means there is some sort of spasticity. And if the status of the abdominal reflex, the superficial abdominal reflex, if the superficial abdominal reflex is absent, then again it means it is going to be like a UMN kind of lesion. And even there is a tendon reflex involving the abdomen as well, where you place the finger over the 4 quadrants and you tap it. So what happens is, due to the contraction of the abdominal wall muscles, the umbilicus will shift towards that side, will be pulled towards the muscle, towards the muscle contracting side. So that is the DTR involving the abdominal muscle. So again you have to look into that status. And then regarding the plantar, so you know that if it is going to be a UMN type of lesion, then it is going to have a extensor plantar. So all these you have to carefully attend. So if any of these is present and the reflex is going to be like hyper, then it's a pathological reflex. A normal extremity tone, intact abdominal, that is the superficial abdominal reflex, and a plantar flexor response, all these are brisk reflex, that is not pathological. So this is how you physiologically distinguish a brisk reflex from a pathological reflex. Now coming to a very important topic, that is the inversion of reflexes. This inversion of reflexes, this term was coined by Babinski. We all know Babinski for his plantar response. And so what happens is, in inversion of reflex, for example, if you take the biceps reflex, what happens when you tap on the biceps tendon? It is going to cause flexion of the elbow. Instead of that, if it is going to cause an extension or an opposite reaction, or some other adjacent muscles are getting involved, like extreme supination or a finger flexion, that kind of reflex is going to happen, then it is called as inversion of reflex. So either the response will be completely opposite due to the activation of the antagonist muscle, or due to involvement of adjacent muscles, there can be another response rather than the one which we anticipate. For example, when you check on the brachioradialis or the supinator reflex, what happens is you are supposed to have supination, but instead of that, when you have finger flexion, it is called as inversion of supinator reflex, inverted supinator reflex. So that is what is called as inverted reflex. So why does it occur? So here basically the local segmental reflex is absent, and there is an underlying hyperreflexia which lowers the threshold for activation of other muscles. So because of this, without a direct stretch of that muscle, you get a response. Okay, so this is mediated by transmission of vibration in the periphery. So when you tap on the tendon, that vibration gets transmitted. So that is responsible for this inversion of reflexes. So that is getting picked up by the hyperreflexic muscles, resulting in additional movements. So some of the examples, like I told you, inverted supinator jerk. So the normal response is going to be supination. Inverted supinator jerk means the brachioradialis is what we are testing. So the normal brachioradialis or radial periosteal reflex, it is going to be supination. That is the normal response. In an inverted response, what happens is contraction of the finger flexors. So so not at all related. So adjacent muscles are getting involved. So that is why you are getting contraction of finger flexors. So this is what is called as inverted supinator jerk. Now paradoxical triceps. So what happens to triceps when you are hitting on the triceps? You are expected to get extension of the elbow, right? That is the normal thing. But in paradoxical triceps jerk, what happens is flexion of the elbow. So exact opposite. So that is what is paradoxical triceps jerk. So where it happens is C7 or C8 radiculopathy, particularly when it is associated with certain element of spasticity. That is radiculomyelopathy. So combination of both. In that setup, we tend to get this. Now inverted knee jerk. So the normal knee jerk, it is going to be knee extension. So exact opposite of that is the inverted knee jerk, where there is flexion of the knee. So all these are some examples for the inversion of the reflex. So this is a very important topic which you have to know. So with that, we have completed the discussion on the pathologies or the abnormalities involving the deep tendon reflexes. And I hope you understood the concepts very well. In the next video, we will discuss about superficial reflexes. All the superficial reflexes we will discuss in the next video. Thank you.